Okay, welcome. This is a quick and dirty review of subgroup analysis YouTube style. The objective is to lead to reporting without distorting, or as a reader of subgroup analysis to have you appropriately skeptical and cautious of the results. This is a paper published many years ago, a quote from Dr. Feinstein, a very famous clinical epidemiologist. I'll let you read it. The tragedy that he lays out is as persistent today as it was then. Well, we're talking about randomized controlled trials. Why do we do them? Well, we do them to create generalizable knowledge that will inform future decision making. And the reason that we emphasize them is that randomized controlled trials are the most reliable way of determining whether a treatment is beneficial. They are time-consuming and expensive. And given these facts, the use of subgroup analysis after a randomized controlled trial has been completed is pervasive. Here's a definition of subgroup analysis: any evaluation of a treatment effect for a specific endpoint in subgroups of patients defined by baseline characteristics. So there's essentially three elements. You're looking at treatment effect for a specific endpoint in a subgroup. Treatment effect, endpoint, subgroup. So, treatment effect, we have lots of different types of treatment effects. They are measured in quantitative in different ways in the form of relative risk, hazard ratio, odds ratios, arithmetic difference, etc. Endpoints include overall survival, disease-specific survival, disease-free survival, toxicity, and any number of other endpoints that you can imagine. And baseline characteristics, there are lots of those as well. The commonly examined ones include age, gender, race, tumor size, tumor grade, etc. The important thing to point out is that these are baseline characteristics that are known at the time of the beginning of the clinical study. Subgroup analysis really gets at the notion of heterogeneity. Heterogeneity in this context means that the treatment effects vary across the levels of a baseline characteristic. So the treatment effect of drug A versus drug B may be different according to age, gender, etc. In different contexts, this notion of heterogeneity is described as effect modification. This is primarily in the epidemiologic literature, case control series, etc., or interaction, which is the term that is usually used in the clinical trial setting. Both of these essentially mean the same thing. Now, we can have quantitative heterogeneity or qualitative heterogeneity. Quantitative heterogeneity is when treatment A is always better than treatment B, but the magnitude of the effect varies according to a baseline characteristic. So at the bottom of the slide, for example, in group 1, A is better than B. In group 2, A is much better than B. So this is quantitative heterogeneity. A is always better than B, but it's much better in group 2 as compared to group 1. This is an example of quantitative heterogeneity. It's really not as important as qualitative heterogeneity because this is the area that people can make mistakes and lead to poor clinical interpretations and subsequent challenges down the road. Qualitative heterogeneity is when treatment A is better than treatment B in one group, but in the other group it's perhaps worse than treatment B. So in this example at the bottom of the slide, in group 1 A is better than B, but in group 2 A is worse than B. This is an example of qualitative heterogeneity, and it's much more important than quantitative heterogeneity. So how do we determine if heterogeneity exists? This is taken from a very important paper that I'll provide to you, published in the New England Journal. The appropriate statistical method for assessing the heterogeneity begins with a statistical test for interaction. You essentially ask the question across all patients, is there a difference according to this baseline variable in the treatment effect? If there is, according to the statistical test, then it's worthwhile to pursue this further. If there isn't, then you should probably stop. Now, one of the problems with interpretation of interaction or heterogeneity effects is that many trials are underpowered to find an interaction. And so the simple inability to find an interaction does not mean that an interaction doesn't exist. It could mean that you simply don't have enough power to find it. A couple of common mistakes that are made with respect to subgroup analysis. The most commonly seen that I see is we have separate tests for treatment effects in subgroups without performing some sort of global heterogeneity test. The other is to sort of non-quantitatively look at the effect size comparison without providing any statistics for that comparison. Let me just highlight a very important issue, which is multiplicity. This relates to the number of tests or comparisons that one makes, and this is taken from a paper in 2006 in the New England Journal that looks at the probability that multiple subgroup analyses will yield at least 1, 2, or 3 false positive results. This assumes that the null is true. So if you do, for example, 10 independent tests, when the null is true, the chance of a false positive is actually 40%. So if you have 3 subgroups that may be with 3 different endpoints, if you do all of these pairwise comparisons, you're inflating your type 1 error, and it's very likely you'll end up with a false positive. The number of significant false positives obviously is less if you ask for more, but if you perform 20 tests, then it's more than 50-50 that one of those, chance alone, will show up positive. So subgroup analyses are not always bad. If they are pre-specified and planned prior in the form of stratification or powering your sample size appropriately, and they're documented prior, that's a good thing. But it's important to recognize that multiplicity applies even in the pre-specified setting. Post hoc analysis is usually what we see. These are analyses that are planned after the trial is completed. They're typically documented after. Of course, multiplicity applies, but what you frequently don't know in the context of the paper that you're reading is that how many of these post hoc analyses were actually performed, or how frequently did they shake the box. And if you remember from the slide a couple of slides ago, it's very simple to come up with a very high number of false positives as soon as you begin to escalate the number of pairwise comparisons. So that's subgroup analysis in a very brief 10 minutes. Please read the paper that I've sent along with this from Wong in 2007. I think it highlights all of the major points. Thank you.